Our first case of the evening is a 58-year-old gentleman. He has relapsed refractory diffuse large B-cell lymphoma and presents with fever and hypotension. He received his cells, and on day +3 came to clinic for his scheduled appointment. We're notified by the nursing staff that his temperature is 103 Fahrenheit, heart rate 128, so he's tachycardic. Blood pressures are a little bit soft at 90/65, and he's 90% on room air. The nurses put him on 2 liters of oxygen by nasal cannula, and he comes up to 91%. Counts are listed here. He's neutropenic. Total white count is 0.3 with an ANC of 0, hemoglobin of 9.1, and platelets are 80,000. His caregiver reports that he feels weak. So we gave him tocilizumab and dexamethasone in our clinic, which is our practice here, as well as a liter of IV fluids, and we admitted him for further care. Upon arrival to the hospital floor, he remains febrile with a temperature of 102.8 Fahrenheit. He's still tachycardic. Pressures have not improved despite the liter of normal saline, and he remains hypoxic with a SpO2 of 91% on 2 liters. At that point, he's determined to be not responding to IV fluid boluses, and he's moved to the intensive care unit for vasopressors.
I said, it's a tough case. Of course, we would start that way. But, if we kind of go to the original presentation before we got the tocilizumab, I guess maybe we can talk about what grade CRS is this patient. So he's got a temperature, he's got a fever, and he has hypotension, and he's requiring 2 liters of nasal cannula. So at that point, and he's on pressors at this point, right? So what we would consider him a grade 2, right? That would be grade 2 CRS, I believe.
Yes.
And so the intervention is fluids and toci, right? Everyone agrees. That's sort of kind of, and then he got dexamethasone as well.
Mm-hmm. Correct.
Now you're in trouble now. Because apparently that didn't work.
Yeah. Well, and I mean, I think one of the other things is he's also a patient with neutropenia who has a fever, right? So he's like you said before, Dr. Bay, I mean, he's in that window. With Cilta-cel, it's day 8 or 9. With the CD19 CARs, it's day 3 or 4. So he's in the window. So I think our suspicion is high, but at the end of the day, he's got a line, he's got chemo, he's neutropenic, and I think he also needs an infectious workup. He needs empiric antibiotics. He needs to have other things evaluated as well.
Yeah, he presents like a typical, a non-malignant patient, septic patient, where he's hypotensive, ICU bound, requiring vasopressors, and so, he's going to get the full course of treatments from a CRS management, but also from an infectious workup management. And so to kind of go off what you were saying, at this point he would be grade 2, but mentioning how he's received a fluid bolus, was put on supplemental oxygen, and by the time he gets to the floor, he's still hypotensive. Then by now he meets criteria for grade 3. And so moving to the ICU, at least within our facility, vasopressors have to be used in the ICU. So that would be where he would go next, and would be in that grade 3 category. Like you said, I think the question is, now he's already received toci and dex, presumably within the past hour. I think it says arrives 40 minutes later. Other than these supportive things, as far as starting pressors, getting him on antibiotics, start doing an infectious workup, as far as CRS-directed therapies, we have a time frame in which we can give more tocilizumab. I guess my question for you guys would be also, at what point would you, continue to watch to see how he improves with pressors versus increasing or additional steroids, or where would you go again in this very acute window?
Yeah, so no, that's why I told Dr. Byrne, I'm like, how do you have to make it this really difficult? Because why can't we start with a straightforward case? So just to bring, because you're bringing all amazing points here. Most patients who present like this, and you are correct, you have to, if he's neutropenic, the patient's neutropenic, you have to do the whole neutropenic fever workup and start breast spectrum antibiotics. But assuming this is cytokine release syndrome, because it is the window is exactly what we would expect, the majority of patients respond to one dose of tocilizumab. It is rare, in my opinion, that they don't. Now, having said that, the response usually, it can take a couple hours. So it's not like it's immediate. So this patient still could improve, right? It's just that you're catching him early. So at this point, I personally would be getting ready to continue the dexamethasone and just leave it at one dose. But I'm not sure I would add anything else from that standpoint. Allow the TOCI, allow the dex to kick in and keep the patient well with the antibiotics, with the fluids, and yes, pressors. And I don't care where you are. I think if you have pressors, even you can do them in your unit, you should place them to the ICU. So what thoughts, Mike? Is that kind of what you would do too, or would you move forward?
I agree with you. I think it's very early. Yeah, 40 minutes is very early. I'd let the drugs do their job. I'd get the antibiotics and I'd support them. I give them more fluids and give them a chance to hopefully turn the corner here. And I agree with you, Dr. Brady. I feel like the majority of people who get TOCI, one dose, they do turn around pretty well, pretty quickly.
And actually, and it'd be interesting. Sometimes the patient tells you first before even they start getting better, right? They're like, "Oh, I'm starting to feel better," and their numbers may not indicate that yet, but the patients often do feel better. So that would be something that I guess I'm curious to how the patient's feeling, or is he just like getting worse and worse, and he's just like out of it. So okay, well that's good, I guess, and I guess I kind of touched on it, but if he continued to have issues. This is the patient where we're definitely a one-time dose of dex. Maybe I can discuss that. So here you decided to give TOCI and dex immediately, and then maybe I'll ask Dr. Burns, since he's the one that is the clinician here, as to why you chose that, and do you continue the dex, or is this truly just a one-time dose until you see what happens?
Yeah, so I think a good question. So I think our practice has moved in that direction for these people. I think within the last few months, we've moved to earlier intervention. So we're intervening early now at the first sign of fever. So grade 1 CRS, we're giving everyone at a minimum tocilizumab, and a number of people who get CRS are at risk for getting ICANS later. So the dexamethasone, I think it also is probably better at treating the CRS, and then our thought process was it's also pushing down the interferon gamma, which we know is the driver of neurotoxicity. In this setting, I would not continue it. I think per our discussion before, this is a guy that also has a neutropenic fever. That I would, if I did anything here at the 8-hour mark, I would probably give him another dose of tocilizumab, but I don't think I would push to continue. I would not push to schedule the steroids in him in the absence of any neurotoxicity.
So in the early days of CAR T, we were afraid of giving dexamethasone because we thought that was going to somehow adversely impact the effectiveness of the CAR T. Is that still an issue?
No, it's fine. I'm younger than you, but I remember those days as well. It was like playing chicken. The patients are going downhill, and we don't want to intervene. And I think we've come a long way over the last almost decade now, and I think the pendulum has swung in the other direction, where we're saying if we intervene earlier, these patients may get less. They may actually get less steroids in the long run, and I very much believe that that's the key to making this as safe as possible, is intervening earlier in these patients.